in today's presentation, I will present the full part. First, I will make a brief update for the ICH guideline, and for the second part, it will be the integrated assessment strategy in our lab, and the third part, I will brief introduction about the comprehensive CPAP ion channel panel and the full panel, and the final part, I will give the translation study for the cardiac safety assessment. Yeah, okay. Next, please. Thank you. Okay, first let me make a brief update about the ICH E14 E14 and I7B guideline. Yeah, we can say the these two very important guidelines is unhurried in the 2005. In the initial words, especially about the guideline E414, it is very strict for the cardiac safety evaluation. It asks every new compound, every novel compound has to be performed with the T2T assay. The T2T assay uh, is very expensive. We can see the T2T assay is a big burden for the new drug development. So when this guideline has been released, there is many discussion about how to optimize the cardiac safety evaluation, and about 2015 years, the E14 guideline has made some modification. It can it indicates that some compound in some scenario we can use the concentration based 2TC model in the phase 1 to assess the risk of the 2TC risk, and it can be served as the endpoint in the clinical choice trial. So it means that if we so it means that some compound will not be tested for the T2T. But however, this region of the compound is somehow very narrow. So we can see that this modification is a very good try. But however, we need more. So we can see there is also many discussion in the clinical, in the industrial, and also in the government. And in the 2022, the ICH issued the guideline update. It issued the Q&A. In the Q&A, the guideline opened a very good door for many compounds that make it clear if the compound is safe for the herd and also for the in vivo QT assay. On this compound cannot be to test the T2T. I think that is a very big improvement. Yeah. Here is the update about the ICH guideline. We can see, yeah, here we can see in the right window, here is the integrated strategy for the industry, how to perform the cardiac safety evaluation. First, if on this compound, we should test the herd assay and also the in vivo 2TC assay. When this assay has the result, we can evaluate if the result is safe, that there's no need to be tested for the T2T. And in the phase 1, we should just to test the safety ECG only. That means we just to do the C2T instead of the T2T. And however, at the early phase, for example, if we find some risk for the herd or for the in vivo QT assay, maybe we should do some follow-up study, and we should put all these results together to make a final decision which type of the clinical assay we should do. So I think that this is give us a very clear strategy how we should to do this for the new compound, for the novel compound, when we consider the cardiac safety evaluation. Okay, and for the next, yeah, I think there is a very big improvement for the for the guideline update. In the new guideline update, he uh, made it clear the double negative scenario. Yeah, that give us a very clear picture. What study should to do to evaluation the compound. For example, if we can see a compound that is negative for the hERG assay and also also negative for the in vivo protein assay, we should talk. We can see that this compound is this compound is follow the double negative scenario that for the in vitro assay or in vivo assay there is no follow-up study to do. And also for the clinical, we should just connect the safety ECG recording. So in this in the two in the double negative scenario, so we can see that all this compound should not be to test for the T2T. But however, if all this compound is positive for the hERG and for the in vivo protein assay, we can see that all this compound has a high risk for the cardiac safety. So for the for the in vitro assay, we should to do some follow-up study, and also for the clinical, we will consider to perform the T2T, and however. And however, if on this compound, he is not negative for one of this assay, yeah, we can consider we can also consider the different combination of the in vivo and the in vitro assay to direct us make the final decision to design the clinical assay. So I think that the double negative scenario give us a very clear picture to tell us how to evaluation the compound about the cardiac safety risk. Okay, next. Thank you. Yeah. Just we said previously that all this E14 and I7B guideline has been updated. We can review the progress of this this guideline. We can see that there is a four step. First, it should to building the technique document to some discussion into the government, into the industrial, and also to draft the guideline. Now, currently we can see the most of the important government agency has been to implementation of the E14 and the SMB guideline for the Q&A. So I think the new update of the guideline give us a very clear picture how to perform the assay. We should follow the best practice, and also he will tell us how to make the decision based on the result. Okay, next. Yeah. Previously, I made a simple summary about the guideline progress. Now I will make a brief introduction about the integrated assessment strategy in our lab based on the updated guideline. Yeah, we can say we should say that when we to perform the safety cardiac safety evaluation, we do not depending on we cannot depending on the only assay to find the safety compound. And also at the different stages for the drug development, we should pay attention to the different points. First, for example, yeah, we should for example, in the drug discovery phase, the focus should be to move forward the compound into the development. So we should design the acid combination to eliminate the potential use. We should to design the acid combination to keep the potential useful drug. In other words, that at the early drug discovery phase, we cannot to eliminate the potential useful drug too early. And when the compound has come into the safety stage or the clinical stage, we should focus more on the safety so that we can diminish the risk of this compound. So we can see that if we can choose different combination of the in vitro assay, in vivo assay, that we can increase the possibility to find the safety compound in the early phase. Okay, that please, yeah. So in our lab, we always to think of one question: how to design the in vitro assay combination that could provide more clinical translation value. So I think there is some simple in vitro assay. When we combine this in vitro assay together, we can find the more clinical relevant compound in the early phase for the drug discovery. So we can say that first we should to do the herd assay, in vitro herd assay. Yeah, the herd blockchain. First, we can discussion about the herd blockchain and the TDP. Yeah, the herd blockchain and TDP has the positive correlation, but it's not the absolutely relation. Yeah, we can see that we always see some compound that maybe has some inhibition for the herd channel, but however, this compound is safety for the herd for the cardiac safety. So we can see that herd is very important, but just herd is not enough. And when we supplement the herd assay with the in vitro IPSCM action potential, yeah, it will be give us a very good result in the early phase to find the useful and also the safety compound. Yeah, and we can see the herd. We can see the herd is necessary for the TDP, but however, uh, only the only the herd inhibition it will not absolutely cause the cardiac safety. And also we have read some paper. It indicated that the APD pronunciation and we have read some paper. It shows that there is a good correlation between the in vitro APD pronunciation and the QT pronunciation in the clinical. So we can see that if we combine the in vitro assay and in vitro IPSCM and potential assay together, it will be a very smart strategy for us to find the safety and also useful compound in the early phase. Okay, next. Yeah, based on our reasoning, we designed the integrated assessment strategy in our lab, just as this picture, just as this slide showed that. First, first the all these compounds should be tested with the in vitro herd assay, and there is some criteria for how to for to decide the risk, yeah, we can use the IC15 for the primary screening to find the compound that is safety for the herd, and to calculation the safety margin based the freezing mass and the herd inhibition, and when we got the inhibition or when we got the result of the compound for the herd channel, we can next we can test the antigen potential in the IPS-CM that we can confirm if this compound is really uh, clinical relevant with the cardiac safety issue. And also, there is some very clearly cut off for the APD assay. Yeah. So just as said that previously, when we put these two type of the in vitro assay, we can find the compound that is safety for that is safe for the cardiac in the early phase. Okay, thank you. Next. Yeah. So all this, so we can see that all the strategy and even the update for the guideline, it is based on the CIPA. Yeah, CIPA is a very good. CIPA is a very good proposal that has been released about 10 years ago. Yeah, here is the CIPA. CIPA is about 4 parts. First, it should to test many compound, many channel. Yeah, previously maybe we just focused on the herd channel, but however, we know that there is other important channel, for example, the sodium channel, calcium channel, that is also very important. First, the sodium channel and calcium channel can balance the effect on the herd sometimes, and also the compound and also, if one compound to the inhibition, the sodium channel and the calcium channel, it also can cause some risk for the cardiac safety. And when we got the data or the result of one compound for this critical channel, we can use the in silico model to predict how this compound could be affect the cardiac and antigen potential. We can see on this the on this part, the first part and the two part for the CPA is the is the primary screening for the compound, and for the third part, we should test the compound on the antigen potential of the IPS induced CM. Yeah. We can see that this assay is somehow we can see that it is a type of the phenotype study. It's not just focus on one specific channel, but however, it will be evaluation the compound overall effect on the antigen potential of the one cell. If we can put all this data, all this result together, we can predict the compound safety profile of the cardiac. That is highly relevant with the clinical result. Okay, so all this our the integrated assessment for the cardiac safety strategy in our lab is based on the CIPA. Okay, that's thank you. Yeah, here is some data. Yeah, we are study about the comprehensive CPA ion channel panel. Just we said previously, there is 3 important ion channel for the cardiac safety, that is herd and sodium channel 1.5 and calcium channel 1.2. Yeah, here we show some data in our lab that is generated by the manual patch, and also we have tested the auto patch with the non-linear patch nanner, and the and in our labs the manual patch and the non patch nanner for the herd, we have a very good correlation, and the data fluctuation. The data fluctuation is also very small. Okay, next. Yeah. Mm, just we see that many the government agency has the best practice consideration for the in vitro study.
We cannot hear you. Can you hear us? Can you hear me? Dr. Zhang, can you hear us?
Yeah. I can hear you very clearly.
Okay, now we can hear you as well. Good. We lost you for a minute there. Okay, all is good now. Please continue.
Okay. Yeah. Okay. I'm sorry. Yeah. Now I will make a brief introduction about the best practice consideration for the in vitro herd assay. There are three parts. There is a very important three parts for the best practice. First, it tell us the condition for the channel recording. For example, we should recording the herd channel at the physiology temperature, and also the voltage protocol used should be relevant with the action potential of the heart. And also we should recording with a very high quality. Two part is the data approach method. We should when we follow the best practice, we should give the IC50 and the hill slope, and we should the 94% confidence interval RCI, and it also tells us if the more than 15 current inhibition could not be achieved adjusted. Yeah, it also tells us that if the 15% current inhibition could not be achieved, a justification of the highest concentration test should be provided. And when we submit the data, we should including the inhibition rate, IC50, input residence, and the current time course, and so on. And also, there should be the compound verification. Yeah, it also tells us how to set the positive control and negative control. So if we follow the best practice, I think the data or the result from the different lab we can be comparable. Okay, next. Thank you. Okay, next. Thank you. Okay, yeah, here is the example for the best practice in our lab. We can see we can see that when we use the practice condition for the herd channel recording, the herd current, the trace for the herd current is not very familiar with the traditional herd current, and also we can see that the protocol is just similar with the action potential, and the recording temperature should be set to the physiology condition, and there is very important parameters to check that the data, the recording is the maintain and the high quality. Okay, next. Yeah, here is our internal data that we used that the practice to test the some compound. Yeah, and as we can see for some compound that the temperature has a very significant impact. Okay, okay, that's for the best practice, we also said that we should to do the compound concentration verification. Here is one example. It's one compound. When the compound is test for the herd response response dose curve. When the concentration is used as the label, we can see the IC50 is about the 500 nanomolar. But however, when we use the LC-MS to verify the exactly the concentration of the compound, the IC15 has changed. We can see the IC15 is about 100 nanomolar. It tells us that it is very important to do the concentration verification about the compound that can tell us how much compound, how exactly the concentration of the compound is applied to the cell. Maybe it will be the very big difference. Here is some reason that will cause the big difference. Okay, next, please next. Yeah. Beside the herd, we also can test the other important L channel with the best practice for the sodium channel 1.5 and also calcium channel 1.
Dr. Zhang,
Oh,
we lost your audio again. Now you're back. Excellent. Okay.
next. Okay, can you hear me? Okay, yeah. For and also for the sodium channel 1.2 herd and calcium channel 1.2, we can test many. Uh, we can also test other important ion channel for the heart. And here is some data result. Okay, calcium channel, sodium channel, and all this channel is very important for the heart. Okay, for the next slide. Yeah, and also KV 1.5, that is very important for the arterial, and also IT1 KV 4.3. All this channel is very important for the heart, but however, that is not necessary. That is not must to test for the cardiac safety evaluation. Okay, next. Yeah, beside the SIPA channel, we can test. We should pay attention to another important ion channel in the herd. If beside the SIPA channel, we should pay attention to other important ion channel in the heart. If we are focus on the disease with the heart, yeah. So it's so we can decide which channel we should be including for the channel for the CPAP channel panel, depending on our aim, our purpose. Okay, next. Thank you. Yeah, previously I just made a brief introduction about the integrated strategy for the cardiac safety evaluation, and also to make a brief introduction about the important CPA ion channel. But however, the CPA ion channel panel is just focus on the one specific ion channel. Yeah, there is will be a dip between the ion channel effect, the ion channel inhibition, and also the the actually phenotype of the heart and the phenotype of the cardiac. So how to bridge the gap? And I think the IPS induced CM could provide us a very good, powerful tool to do some translation study for the cardiac safety evaluation. For this picture, we can see there is a very good correlation between the APD pronunciation and the clinical QTC. So we can use the antigen potential assay as the supplement for the herd assay for the ion channel study. Okay, that's yeah. Mm, there is a different assay format for the action potential assay. Now I can see now we can see that many the action potential assay is test is performed in the IPS induced CM. We use the E we use the E4 E031 that is a positive control for the herd, and this compound can be specifically block herd. So we can see that when this compound is applied to the IPS-induced CM, firstly, it can make the action potential duration prolongations significantly and in the dose-dependent manner, and also at the top concentration or at the high concentration of this compound, it can induce the EAD. So that if we consider some compound can use the EAD, it is very clearly indication that this compound is risk for the cardiac safety. Okay, next. Yeah, and also we can use the tissue. For example, we can use a rapid protein fiber to test the antigen potential prolongation. That is also very powerful tool to assess to evaluation to assessment the safety cardiac and the rapid protein fiber is somehow sensitive to the herd blood, and also we can see as we use the herd specific blood, we can see that with the increase of the concentration, there is a significant prolongation about there is a significant prolongation of the APD duration. Okay, next. And also at the higher concentration, the herd positive control compound can induce the EAD. So I can see that when we consider the APD, when we consider the action potential assay, we can use the IPS induce the cell, and also we can use the rapid we can use a rapid protein fiber assay. Honest to assay is it is very powerful, and also honest to assay is acceptable by the FDA. Okay, here is another type of the translation study for the cardiac safety assessment. Is about the Lendendorf, and also it is a very powerful tool and can give us many more parameters. Okay, next slide. Yeah, here is some data for the Lendendorf assay. We also use the herd blocker. We can see that that can significantly prolongation the QT. See, yeah, okay, next. Yeah, here is we use the another herd blocker CC spread. We can see that CC spread to the significant prolongation the QT interval, but it does not affect the another parameters. Okay, next. Yeah, here is a one case study. Yeah, so I can briefly to talk about it. Yeah, we have tested one compound that has a very big inhibition for the herd, but however, this compound is safe. How we could be evaluation? First, we can see that we use the two type of the action potential assay. We can see one is with all these two assay at the concentration below 10 micromolar, it is safety. It will not cause the prolongation of the entry potential. However, when we test the different type of the channel in the heart, we can say it can also block the calcium channel, so that maybe the inhibition for the heart channel and the calcium channel can balance each other. So the overall effect of the compound is safety. Okay, next. Fine. So here is all the presentation about how we can do the integrated assessment about the herd assay in our lab.